the keynote, the first keynote lecturer today. And you've probably all heard about Norman Daniels. Or Madly, I know many of you have an intense intellectual relationship with him. And my relationship, intellectually, with Norman Daniels started in my very first years of the university, when I studied philosophy. And I was reading a book which was called Reading Rawls, which I think many of you have read. And that, so when I met Norman Daniels in person later, when I started to become very interested in the role of so what is just priority setting in health, because I had someone else very close to me who was very interested, that you will also meet, who's very interested in that. Then, of course, I came to know another part of your intellectual work, Norman, and that has been so incredibly important, which is the work on accountability for reasonableness. And because, of course, in all societies, the question of how do you get most health for most people in society with the resources that you have is an incredibly difficult question, and it's getting more and more difficult, because if you go 50 years back, medicine couldn't do so much. So you could basically, it was so difficult to distribute the resources, but now the gap between what medicine can do and what the resources that we have to do it with is just widening and widening. So the question of how do we not only make more effective medicines and generate more resources for health, but how do we divide the resources that we have in an equitable way and in a just way is becoming more and more pressing. And it's becoming pressing in all societies. Even the richest societies can't pay for everything for everybody. And the poorest societies certainly cannot. So the question of how do we distribute the resources is becoming more and more important. And then there is also a difficult tension with rights in this complex field, because of course the right to health is ambitious in the sense that it says that the right to health is the right to sort of a full mental and physical health. And beyond. So it's sort of a very ambitious, it says that, so if you have the right to health, what does that mean in a society when resources are scarce? So that's what we're going to discuss today. And that is the field that Norman Daniels has been working in for many years. And so Norman Daniels, professor of Harvard School of Public Health for many, many years, a very important intellectual force in thinking around just priority setting in health. We're so happy that you were willing to come to Bergen to give this introductory keynote to set us off in a good way for the Bergen Exchanges. So please. Okay. 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 So did you? Okay. Okay, so then I'll, because I was going to introduce you before the panel.
No, so I want to introduce
Okay. Okay, so there was a little bit of unclarity on my part. So I'm going to also introduce someone else who's incredibly important for the health and the law part. I was going to do that after the lecture, but I'll do it first. Alicia Yamin was the one. We were the ones who were talking about doing health and the law as the focus area this year. Alicia is a lawyer from, I came to know you when you were working at the Harvard Law School first, then Harvard School of Public Health, then you moved to Georgetown. You also have a background in public health. You also have a background working in various organizations and on the ground, and also at the international level. So Alicia is, and has written extensively on issues related to health and the law. So that is why you'll see a lot of Alicia today. She'll be moderating many of the sessions, and she'll basically be the main person in charge of the health and the law part of the Bergen Exchanges this year. So now, that was the short introduction. Please, take the floor.
No, so I just wanted to introduce Norman as well, and I will refine my remarks because Siri already said much of what I wanted to say. But for those of you who may not be familiar with his work, I think when Norman entered the field of ethics and health, it was replete with bioethicists. And Norman's work was really, you know, a lot of people use the word groundbreaking. It was disruptive, it was transformative, it was game-changing in moving to an understanding of population health ethics. Using Rawlsian philosophy, and as you all know, John Rawls in A Theory of Justice didn't really deal with health. He later came to do so a little bit. But Norman has developed that a great deal and has really had an influence on shaping the entire field, I would say, starting with the very simple and yet critical question of when we cannot meet all health needs, which we can't, whether we're in Norway or whether we're in Ethiopia, as we'll discuss, how can we do so fairly? And I also think that having worked at Harvard and had him as a colleague, it is extraordinary to find somebody who has made the contribution to the intellectual field that Norman Daniels has, who is also so intellectually generous and generative with students, which, if you know Harvard, is not necessarily the norm, but he is universally beloved by his advisees and students. And I personally think it has been one of the great professional privileges of my life to be able to work closely with him, to be able to discuss and bounce ideas off of him, to collaborate on various projects with him. And certainly he has opened my mind to thinking about justice and health and rights in new ways. So I just wanted to say that so that really we are incredibly lucky to have him here. And I'm very much looking forward to the conversation.
Okay. Is it on now? Okay, I see a lot of nodding. So I wanted to talk to you today a little bit about rights as a starting point and versus rights and the theory of justice. And then I wanted to talk a little bit about the necessity of priority setting. And I then wanted to go into Rawls's theory of justice and the idea of a fair deliberative process. And I wanted to talk a little bit about priority setting in human rights. And I will leave the focus on children to the roundtable that follows our discussion, and that will be introduced by my longtime friend, Ole Fridtjof Norheim. So I wanted to start with talk about a little bit about rights and starting points. And in Just Healthcare in 1985 and in Just Health about 30 years later, I claimed that rights to health should derive from a theory of justice for health and not be a starting point in thinking about what we owe each other. So I contrasted this view with the practice of many to declare that they have a right whenever a strong interest is felt. So the starting point approach, let me respond to the suggestion that a lot of people have that we could start with rights. And I think that is a lot of the focus of human rights activity. Start with rights, and I wanted to say, let's start with the focus on justice and healthcare and derive the notion of rights from that. And that is one of the foci of my work over many years. So let me say a little bit about what the is a failure of the starting point approach that I'm countering. And I think it fails to give us clarity about the entitlements that follow from right claims, so that we don't know what the appeal to law would yield if we say that something is a right, someone has a right to health. What does that mean? That they are entitled to anything that works, regardless of what the state could sustainably afford to provide them with, or not. And that is the fundamental problem of judicialization in health. I think that the starting point approach fails to give us clarity about the entitlements that follow from right claims, and fails to determine what beliefs count as adequate justification for right claims. And it fails to help us clarify what we ought to get from the law, which is, and in later work, in a couple of years ago, I wrote a paper which, in healthcare analysis, I claim that two functions identify which are specifying entitlements and raising resources to fund them, must be present for any claim to health to be a right to health clear to be true. I wanted to talk about implementation of a right to health, and that is what I did in that paper. And holding a state responsible for meeting the claim that someone might, a claim that someone may have that she has a right to health, certain health services requires that those functions be met by the state. That is, specifying what the right claims are, entitlements to, and funding them. So a lot of the international work focuses on clarifying that relationship. I wanted to talk a little bit about the necessity of priority setting. And this would be relevant if you had the view about justice and health policy that I have, so that however important health and healthcare is, it is one of the only goods, it is not the only good that compete, and it does compete with others. So whatever budget we allocate to health must be compete with budgets for other things. And investing in some inventions will be unsustainable for any system. Interventions, an investment in interventions will be unsustainable for any system. And this has led to various efforts at priority setting. So that's a very important point, and I wanted to sink in. It is commonplace in human rights work to think that the rights clarify everything, but I'm suggesting that they don't, and that one needs foundations for them that might clarify. But I want to argue that you don't clarify the right to health just by providing foundations. So I wanted to talk a little bit about the theory that I've developed and developed from Rawls's foundations in the theory of justice as fairness, and extended to healthcare. I'm not sure what familiarity many of you have with that theory, but the idea is to approach principles of justice from behind a veil of ignorance and choose them, but get around the objection that has often been raised to many contractarian theories of justice, that they fail to take into account the notion of fairness. And the idea is that you could have a fundamental judgment about opportunity and justice for health that is central to your approach, and I do. But unless you correct for the imbalances and biases that people would bring to an approach, you won't have a notion of fairness at work. So one of the contractarian traditions that led to work that derived from John Locke, the English philosopher, was criticized for having he brought property to bear as in his original position. You had a starting point that didn't correct for the biases that property would bring to health care. So you have to step back from that and invoke what Rawls called a thick veil of ignorance over your choice situation, so that you don't know what property you have and what your level of wealth in a particular society is. And that is very abstract. And many people I've learned don't abstract from their place in the world. And that is one of the hardest things to do. In order to achieve a fair starting point, one would have to make that abstraction. So the conditions that are necessary for proceeding would insert fairness centrally into the theory and make the judgment that health system must protect basic liberties and opportunities, which is where Rawls came out on this notion, even though he started with the point that he abstracted from health and wasn't concerned with who was worse off to start with. But he later added that if you want to extend my theory to health, you'd have to protect the basic liberties that you would choose from a position in which you didn't know who you were and you didn't know anything about yourself, to a position in which you did know that, let's say, you had certain capabilities that were diminished compared to others. And that's a very hard abstraction to make. So one of the approaches that I made was to add to his theory a deliberative fair process, which is called, unfortunately, and I would welcome suggestions about a better name for it, accountability for reasonableness, which is quite a mouthful in English and in any language. I worked on this theory with Jim Sabin, who was a collaborator, and a psychologist that I got to know before I moved to Harvard. And I worked with him, and we developed this approach that focused on 4 conditions that had to be met. If you were to add a deliberative process to health care selection of the priorities that and the idea was to focus on legitimacy and to yield entitlements to health care that were fair to all. So you might ask, what is the relevance of publicity to these conditions? And this presupposes a democratic background for the approach. And it's not one-size-fits-all theory. It presupposes that that condition is met, that you're focused on a democratic process as a precursor to the rest of the theory. So we, in the publicity and relevance conditions, presuppose especially that all democratic approaches, all approaches would fit into a democratic approach. But that isn't true, that democracy exists around the world, and it's being threatened in many places, including the one I come from. So this is a challenging context in which to work. The approach of accountability for reasonableness presupposes that condition, and also the publicity, relevance, and revisability, which are the 3 substantive approaches or conditions that I talk about a lot in the 2008 and 2002 versions of accountability for reasonableness that I argued for in a book with Jim Sabin, has to be expanded to include, so the Rawlsian approach has to be expanded to include this accountability for reasonableness approach. And that is making explicit something which you might not have as an explicit feature of deliberation. So my former colleague Dan Brock challenged me to raise the question whether this would enhance fairness as well as legitimacy. And his concern was that philosophically down the road you might want to leave room for a philosophical solution to something you didn't have at the time that you had a deliberation about what to do. So you might not have enhanced fairness in ways that you would not revise. And you would otherwise be in the position of saying, that was fair, but at the time, but it's not viewed as fair now, later, when we have this philosophical approach. So my strategy for that is to suggest that fairness be the most fair approach that we could arrive at a particular time, and we would allow for fairness to be defeated by something that produced consensus agreement around a position that we later had. So I would want to revise the former deliberative process to include the philosophical solution that emerged. And that would be a way to later revisit. And that is what I meant by revisability. You would want to look at all the arguments over again. So the conclusion I arrive at is that fairness is enhanced if you pursue this approach over time. And this is true even in the face of the objection that Dan Brock brought. So let me refer to work that Sophia Gruskin and I did about when she was a colleague and collaborator of mine at Harvard about a decade ago. And this is an approach that was groundbreaking at the time, and it may be old hat to those of you now, but in the field. But I want to emphasize it because I think it's centrally important that people in human rights realize that the approach that appeals to rights doesn't automatically carry the entitlements with them, but it needs a priority setting process to clarify what is owed to people. Sophia Gruskin defined a human rights-based approach as stakeholders, including government officials, recognize the legal imperative to respect, protect, and fulfill rights relevant to health. This was a broad cluster of rights that and they specified the overall responsibilities of the state in that view. And that there was a primary responsibility on governments to determine using evidence which interventions are most important. And that's the responsibility for the impact of decisions and the manner of decision-making is included. So it's a twofold responsibility. The impact of decisions have to be accommodated, and the manner of decision-making has to be, and that's what we tried to capture in these, Jim and I, in these conditions. And what we persuaded Sophia of was that the human rights approach faced a priority setting problem that was best addressed by something that came out of a different tradition, the distributive justice tradition. And an implication of that is that there would be a concern for equity that followed from the accountability and transparency. And Jim and I made a particular compromise in that we thought that at the time that the publicity condition and the relevance condition would accommodate all concerns about and would not be subject to rejection from the prominent makers of health that in the population that we were concerned with, the managed care organizations in the U.S. So you may quarrel with the compromise we made, but what we did was say that the fairness of relying on publicity was dependent on the background conditions of democracy, and that even if the private players in the U.S. would not be required to participate and involve their stakeholders, all the stakeholders affected by a decision, in their decision making, that you could make up for that fact with the strong requirements that we had about publicity. But I'm not sure that that compromise that we made is effective. So Sophia argued that the human rights movement was, and I agreed that it was a positive development in international health, and it established very clearly government accountabilities. It broadened the focus beyond the health sector, so that there were upstream, what is viewed as upstream by many people, the legal structures of a society. For example, in reproductive health, the amount of inheritance that a woman could claim would affect the rights to divorce and the possibility of divorce from a male without falling into dire poverty. If you don't have that, then the right to reproductive health and marriage rights of women are compromised. So the human rights movement emphasized good governance in a society, and so in the United States currently, we don't talk about human rights under our current president. There is a hair-wrenching and hair-pulling climate about the good governance that is lacking in the U.S. now. The human rights approach has a considerable overlap with some of the work that I argued for from a perspective of roles in justice and health. And it ignores a crucial priority setting for problem, which I wanted to return to. And I want to do this without presupposing foundations for health, which may be a more controversial topic in this room. So some might think foundations would resolve the priority setting problems I'm going to address, and it is a lack of them which causes the problem, but I don't think so. I think that you have priority problems, setting problems anyway, and general principles of justice undetermined key rationing problems. So to do human rights determine these problems, because there's no ranking of the importance of the rights within the theory. So I wanted to talk a little bit about the lack of foundations for and the fact that I'm not presupposing them in talking about priority setting. So I could talk about a moral and human right to health care. And I think that we have a moral right in the approach that I've described. So if we take the Rawlsian account and talk about the fair equality of opportunity, and by fair, let me go back to a point that I didn't make before, which is that I would contrast fair equality of opportunity with formal equality of opportunity, and argue that we are concerned with the role of poverty in misdeveloping certain talents and skills of a large part of the population. So when my president talks about selecting people for merit, and he's talking about the skills that people present for jobs now, but not about the skills that they might have if they were trained in various ways by a better education system. I don't think we will get a better education system federally in the US. And globally, I'm hopeful, but I don't know whether that will happen yet. So let me say that the contrast which Rawls made between fair and formal equality of opportunity is simply the contrast between which groups you discriminate against historically, and you may prohibit discrimination against race or women or whatever group that you might think of as, but if it's discrimination against the background of people being trained in a social system that had a lot of people in poverty and and having bad access to education, which corrected for those problems or attempted to correct those problems, then you may have not produced fairness in the outcome, even if you focus on the selection of people for merit who are capable of performing certain jobs. So Rawls is arguing for the correction of that before you select for merit. So you'd want to have the fair distribution of talents and skills in a population as the basis of selection of people for jobs. And that would mean having adequate education for the lower parts of socioeconomic spectrum in all countries that are before one talks about their merit. Otherwise, you're serving the vested interests. So let me turn to the issue of entitlements. So I have in these two columns on this overhead a moral right to health, and that is the framework for that I've worked in previously, and this is the human rights approach. And I want to suggest that in the bottom bullet, the priority setting problem is the same. So that Jill might have a human right to health care, and suppose an intervention, a treatment, offers T1 offers Jill the best chance at meeting her health need, and let's say the same treatment offers someone, Jack, the best chance of meeting his health need under in the moral right to health, but Jill has an entitlement to T1 only if T1 is included in the service that the government agrees to provide in an effort to progressively realize the right to health. So it's in the third bullet that I find the bearing of this concern about the priority setting that is brought out in the fourth bullet. I think the root of that is the view that we all know what a human right is, and that a particular right to health would mean Jill should have, let's say, the treatment one. But if it's progressively realizable that a particular society should do this, then whether or not the government agents who are approached think it's fair matters to the priority setting. And if they think that they can afford that, then they will include it in the budget, or should include it in the budget. If they don't think it's sustainable, it's perhaps beyond the reach of that society. And that is the priority setting problem that we need to address. So let me continue with the argument that Sophia Gruskin and I developed, which is that, and we were looking at a country that she refused to declare the context of, but let me tell you in secret, and this is not in public yet, that this was based on work that she did in Indonesia. And that is the country that is reflected in these statistics at the time. And suppose it was a low and middle-income country with a sizable portion of the population living below $2 a day, which was one of the two estimates of poverty, impoverization, and the maternal mortality rate is 310 per 1,000 births on the average, but it's much higher in the low-income states in Indonesia rather, and 62% of all deliveries, and that would include in the developed cities, in Indonesia have skilled attendants. The disaggregated figures, as I suggested, show a greater geographical inequality, and the adolescent girls and young women have 2 to 4 times the mortality rate of others. And the legal obstacles to unmarried women getting family planning are extensive. So you might think that a human rights approach would, without a priority setting problem, would address this. But the argument I'm making now is that it doesn't. The outreach program for family planning, so 1 through 3, all address the needs that women have for, and who have a right to health care, for rescue from problematic labors. So they could be sent to a hospital by 3. I don't know what that was. Better? It's not. It's on. Okay, I will try to proceed without startling you. Can you hear me now? No? Okay, I think you can now. I was seeing a green light, but it wasn't really on. Okay, now it is. So what I was suggesting is that each part of the problem in 1 through 3 gets people at a certain part of their access to the right to health, but it's the same right. This encounters standard distributive problems in that and you could see this if we take one of the standard distributive problems and address how much priority is happening to the worse off, young mothers versus others. So all of those 3 the first 3 affect people who are at risk, direct risk, and have a right to health. But some are more upstream than others. The ones in 3, for example, are people at risk of not being diagnosed as needing hospitalization, at greater risk of having a child. But the same right is being threatened as in 1. There's no outreach plan, a program for family planning. So the standard problems, the standard distributive problem that is addressed by, let's take the example of how much priority do we give to the worse off? Who's worse off? People who haven't been detected yet, or people who face the higher risk? Maybe people who face the higher risk now are, but that would be a program that would depend on the appropriate sorting of people earlier in their labor or pregnancies. And that's so if a state had limited funds and had to invest in one approach rather than another, what do? Do they build more surgical facilities, or do they have a better outreach program, as in one or two or three? Do they? So the suggestion I want to make is that what the government should do is to improve the satisfaction of a human right to health in a population is the progressive realization, and they know that, but it's not very clear which approach you would take and which priority intervention you would give. And the other, so to improve the population health in the name of the right to health, should that be the focus of what the government does? And maybe it should be, but you have to select the best response. What is the best response? That is unclear. And it's unclear to anyone. It's unclear to the lawyers, and it's unclear to the stakeholders in a population who are affected by the decision that it's made. It's unclear, or do they respond to the individual claims that somebody's making that has these rights? And this raises the judicialization problem. So what I'm suggesting is that accountability for reasonableness, which is the A4R acronym, and human rights have strong compatibility. And the involvement of stakeholders in the vetting of the rationales is important for the legitimacy of a decision that's made. And it's important for the transparency of the decision. In recent work, I've worked with Muriel Getzgebur and Rob Baltuzan, and suggested that you combine MCDA with A4R and get a better evidence base than I described with Jim in the accountability for reasonableness discussions of the relevance condition in the books that we edited or wrote and edited. So the suggestion I'm making is that you could correct for vagueness in the progressive realization approach by reducing through the publicity condition and the vetting of rationales by the priorities among stakeholders and the track record of decisions over time to reveal the commitments of realizing rights. And you could eliminate this vagueness condition so you'd know through the publicity condition which approaches work. And you could remove the fig leaf argument about the federal government, the unwilling government hiding behind the progressivization name, but not promoting the access over time to the service. And the publicity condition would defeat that. So I'm suggesting that the human rights approach, and Sophia Groskin and I were suggesting that the human rights approach would be well advised to acknowledge the priority setting problem in health. And I think that's still a problem in the human rights approach. Well, I've used up my time. I have two questions for subsequent fairness. One is the roundtable that Ule is going to conduct. One is on the global right to health, and I'm worried about what to say if there's no evidence of feasibility in a particular context about the priorities. And with regard to children's rights, I'm struck by the fact that there's utter silence from the human rights community about Trump's leaving behind the children and separating children from parents when that is a right of children according to the human rights conventions that were signed and the lists of human rights for children, that children should live with their parents unless there's a contravailing condition in their best interest. The suggestion I have is that there be an adequate testing of drugs for and other interventions for children, and that is still missing in the approach to drug trials that are ongoing. They're focused on adults and not children. And we often don't know what dosage should be given to children. So if you're interested in children's rights to health, then you would want to address that problem.
I'll introduce my co-panelists. I actually haven't met you.
No, it was Jesse Tomati.
From
Philosophy.
here. Okay, so we actually have a number of colleagues. Jesse Tomati from the University of Bergen here, Department of Philosophy. Ulla Fridtjof Norheim, I think most of you know. He was the head of Norway's Priority Setting Commission. He and Norman and I have had the pleasure of working together on a number of priority setting and ethics issues with WHO and UHC. He's also a clinician, both here and in Ethiopia. Roberto Gargarella is a a sociologist and legal philosopher from Argentina, a Rawlsian who's done a lot on deliberative decision-making. And Christine Underheim is also a clinician who has done work on priority setting for children's health in Ethiopia. We don't have that much time left. I thought I would just have a quick roundtable and then open it up for questions so that all of you can have an opportunity to ask Norman and other co-panelists. I wanted to make two very quick clarifications and then ask the panelists something, and of course they can also respond to the questions that Norman presented before. One is, of course, we're taking for granted as a starting place that what we consider fair and just in health is not what you can pay for, which is another way of thinking of fairness, often about many things in society. And I think we started at a place of thinking about why that is, why health is related to the preservation of a normal opportunity range, et cetera. But just for those of you who aren't immersed in this area, that's important to start with. The second thing, I think, which came out in Norman's talk, but is worth making explicit, is that priority setting is part of justice in health. It also requires a fair financing of the health system. There are micro, meso, macro determinants, what health is financed compared to other rights that are values to us, as Norman pointed out, and social determinants, social and political determinants that actually go beyond the national context. And I think we'll talk a little bit about that and global health justice. The other point I want to make, which will connect to other talks throughout the exchanges, is that, you know, how do we address some areas of sexual and reproductive health, and in particular abortion, which there'll be another panel on, in terms of priority setting through this kind of mechanism and process, and what criteria do we apply? Is it different? Does this presume that there's no comprehensive moral theory behind the decisions that are used to set priorities? So I'm just going to leave that there, but it's something that will come back again when we come to abortion. So my first question would be to Ole Fritjof, and really because you've worked at so many different levels, whether you see priority setting for children especially, but in general, differently in Norway than in Ethiopia, and what that means if we're thinking about a right to health that is progressively realizable within a context. What does that mean for global health justice? Is a right to health very, very different in Ethiopia than it is here?
No, I wouldn't say so. And I'd like to just mention a couple of examples. So in Ethiopia, as in a lot of low-income countries, there is now a big debate about expanding access to health services, not only to mothers and children, because life expectancy now in Ethiopia is 65 years. So people are starting to demand cancer treatment, treatment for pain relief, treatment for cardiovascular diseases. And there's a tension now about kind of expanding those services and completing the unfinished agenda of saving children and mothers. That's still a lot of premature deaths in these countries. In Norway, we have similar tensions at a different level, but exactly the same kind of tension. So one example that's been running or being debated the last year in Norway is access to a very new expensive drug for spinal muscular dystrophia. And that's a disease for the worst off group among those children. Life expectancy is less than 10 years. And just recently, the UK rejected reimbursing that new drug. We don't know exactly how effective the drug is. We know that some of them who would be confined to a wheelchair might be able to walk, and we hope that they will be able to live longer. But the cost effectiveness of this drug is about 16 million Norwegian kroner per healthy life year gained. So in the UK, where they use cost effectiveness as the basic criteria, they said no. In Norway, we have 3 criteria: cost and effectiveness and severity of disease. So we are kind of bringing in these principles from distributive justice. We argue that distributing health fairly is also important, not only maximizing health. So in our system, we would assign a different standard to children or those who have the worse off, who are worse off. And in this example, they would clearly be worse off because they could not expect to live up to live a healthy and normal life. So their opportunities would be clearly restricted. So that would be a substantial argument for assigning a special right to the worse off in this sense. But there are also procedural rights in our system. So we have both these principles for priority setting, but we also have adopted, I would say, Norman's proposal of having a fair, legitimate process. So for children, I think they cannot really participate in processes around priority setting, and they are not always well represented. Maybe their parents, they often fight for their children, but if in other contexts you have parents living in poverty, the state also have to protect children's right and also the right to participate in the procedures. So I would say in the system we have in Norway, and I could come back to Ethiopia, we would argue that it follows from principles of distributive justice and from ideas of fair, legitimate process that we need some special protection of children. And in that sense, the outcome of this reasoning would be, yes, I think we need different standard for children, and we need to formulate a specification of children's right to health and healthcare. So that would be my way of translating what you have been defending for so many years into a very particular Norwegian debate. And I'll come back to Ethiopia.
Okay, so I think I'll move on and ask Christine a question that goes basically to the same point. I think many in the room will be thinking about the entitlements that we actually have access to in Ethiopia are very different than those that a child has access to in the United States or Norway. And to some extent, the Millennium Development Goals and the development frameworks that have gone on have really emphasized child health and mobilizing financing and investment from northern countries to southern countries. There was one MDG related to children's health, and it was very much of a downstream emphasis on certain specific factors. But during the last decade and a half, I would say that at the global level, there has certainly been a focus on child health, on the continuum of care between reproductive, maternal, neonatal child health. So how do you think that that global influence and the kind of governance effects of global development discourse plays out in a place like Ethiopia?
Thank you for that question and for relating this very big and important discussion to what's going on at country level and at the local level. So I'm a medical doctor. I work at a hospital in Norway in Ålesund, but I did my PhD here in Bergen looking at priority setting in Ethiopia, where I looked at intra-household decision making. So I'll try to bring some of that perspective in trying to answer your very interesting and important question. So when I started working in Ethiopia in 2011, a lot of attention was given to children's health. And through the MDG and SDG area, children's health and newborn health has gained a lot of attention. And when we talk about reductions in child mortality, Ethiopia is one of 4 low-income countries that actually met the Millennium Development Goal on child survival. So there was a reduction in child mortality of more than 50% between 1990 and 2015. So it's really, really good. But then I came as a researcher, and what I saw in the policy documents in the MDG declaration, but also in Ethiopian policy documents on giving priority to children's health, was not really visible in the clinics. So I came to wonder what was actually going on the ground. And as Ole brought up earlier, the healthcare system in Ethiopia is quite different from the one where I work in Norway. So in Ethiopia, there are less resources for health, there are fewer healthcare professionals, and more than a third of the population live below the poverty line. And the way the healthcare system is set up also means that families have to pay out of pocket for seeking healthcare. So when we talk about resource allocation, we tend to think, or I used to think about policy decisions, philosophy, and different stakeholders at place. But what I studied in my PhD was actually what kind of allocation decisions did families make. So we asked families who had sick newborns what mattered to them when a child or a newborn became sick. And what we saw that in this setting, where families have to pay out of pocket for healthcare services, we saw that they constantly were struggling between thinking of what would be the best for the baby and what would be the best for the family. So there was a trade-off between concerns for the health of the child and concerns for the welfare of the family. And one of the examples I often give in this setting or from my study is from an interview with a mother who said, should I really have to sell my sheep or sell my cow to be able to afford medicines for the baby? And then she knew that that would have horrible implications for the rest of the family. So even though Ethiopia and the world has paid a lot of attention to child survival and to the rights of the child, I think that the resource allocation decision that's happening on the ground, whether it's in Ethiopia or in Norway or elsewhere, they may look very different from the discussions that we talk about at global level. And I think that when we talk about priority setting in policy making, at meso level or at micro level, we should really take into account what's going on. And I think my interest has been really in what's going on the ground, and I think that what's going on the ground should also influence and shape our discussions on priority setting. And I think your presentation really highlighted how should we think about this, and that require deep philosophical analysis, but also based on the challenges that families and patients face worldwide.
Just to elaborate on the question that Ali raised, do you think that poverty reduction for Ethiopians would be more important than increasing access to care for that child that in the family that you were describing?
I think poverty reduction is crucial and it's urgent, but it takes time. So I think in that setting, the work on universal health coverage that has been and is going on in Ethiopia, and Ule and others have been involved with, it's really important to look at the level of out-of-pocket expenditure. So if you say that you give priority to children's health and that mothers can give birth in facilities, these services need to be delivered for free. So I think the simple answer is we need poverty reduction and services. But when we talk about giving priority to child health services, these services need to be affordable.
So I'm going to come back to UHC. Many people believe that the MDGs did the opposite of what Norman is talking about. So they were globally set priorities that made very aid-dependent governments totally accountable to donors instead of to their citizens and populations. But I want to focus 2 questions on the right to health and rights realization and how it relates to priority setting, especially something that came up in the end about judicialization, Roberto. And what role, given that health involves so many different trade-offs at so many levels, and children's health is a subject of special protection under many national constitutions as well as international law, what role how can we make the 2, priority setting and judicialization, match? What role do courts?
No, that's also super important. No, I was thinking, I mean, out of this question and also following what Norma and Ole were saying, what are the best procedures to express our commitments? And I see that in order to address health issue problems, we need to follow a democratic conversation. And so for me, the idea is how to design a democratic procedure that allow us to decide these important questions and taking into account the kind of injustices that characterize our society. Because, I mean, we cannot just build that democratic procedure ignoring that we are building democracy in circumstances of inequality and injustice. So one way to address problems of priority setting, etc., would be the call for experts, and that's also many times the call for judges. And so for me, the only reasonable way for judges to intervene in the process is for them to assume that they have to collaborate in this democratic conversation. So instead of them taking the place of what we collectively should decide, they should cooperate with us, assuming that a more, say, cooperative democratic role. So their task is to contribute to a democratic conversation. So that's why I was very much interested in what Norma Dials was saying when he challenged the rights approach, that in a way, I mean, calls for the participation of experts and judges in the final decision, and I think that we have to take the alternative, more democratic approach. So I think about these issues like thinking, so what we in a small community or in a family would do if we have, say, 2, 3 children with problems. Well, we sit down and we talk about what to decide, but this is something that we need to talk collectively, and we need to decide this through a conversation. So for me, the role of judges, I mean, should be seen in this kind of so they should participate with us in the collective conversation. So their intervention should not be as it used to be. So they decided more or less discretionally according to one single case, but I mean, they should assume that they are going to participate in a decision that is collective and a decision that has to be taken through a conversation. So the final question will be, I mean, how to better design the procedures for the fair deliberative process. No? So that would be and you too, I mean, have been doing a lot for, I mean, thinking about that. And I would like also to hear more from you too about how you conceive of the fair deliberative procedure. No? I don't know if you want to say a word.
Well, I think we don't know enough to characterize that, and we have to do more research in a broader way on what counts as managing the particular interests that people have and are likely to express. And so one of the concerns I have is that how we don't know enough about how to manage a discussion that is focused on a fair deliberative process. And we know that if you leave token representatives of a particular view unsupported, they will be quiet and they will defer to others. And it would be very hard to bring them out. So what do we do in that case? And we also don't know much about how to manage the power that people have through charisma in a particular setting. And we know this from jury trials. And we've all seen prominent movies that focus on the power of particular individuals to change the vote of the jury. So I think we have to learn a lot more, and we don't know enough.
So just a response to Roberto. So I think the Nordic countries have experimented with this a lot. So both in Sweden and in Norway, we have kind of adopted Norman Daniels's approach. In Sweden, they talk about öppna prioriteringar. And in Norway, our commission on priority setting was called Open and Fair. So the way we've organized this debate in Norway, we started in '87 with public commissions on priority setting. So a government commission is assigned to deliberate and propose principles and criteria for priority setting. And we have a hearing system, so all affected parties, patient organizations and other can comment upon this, and we have had a lively debate on these principles. And the principles that we proposed a couple of years ago was debated in Parliament and approved by the Parliament. And then it was implemented. So we now have a system in Norway with a standing committee that make decisions, and we have a full process to produce the evidence so that they can make good decisions. What we don't have now is full transparency around these decisions because there are secret price negotiations around new drugs. So it's far from perfect, but I think in the Nordic tradition, it's been possible to organize this process so that people know about that priority setting goes on, and they know a little bit at least about the principles, and it's possible for them to learn more. So that's at least a start in the way we have done it here.
Just let me just let me underline. No, I think that's super important. I mean, also for us spectators. I mean, to learn from those kind of things, because I mean, of course, we are going to always to have biases. So. And we want to avoid those biases, and we want to design procedures that help us avoid biases. So representatives may be, I don't know, depending on the people who pay for them, or medicals, or companies, etc. And judges, maybe they have their own isolation problem that also makes so a kind of open procedure. I mean, with public hearings, etc. So of course that may be imperfect, but help us, I mean, minimize the presence of certain biases, and that's maybe all we can do. So we'll be always imperfect procedures, but should be designed in this kind of way. So looking for transparency, looking for openness, looking for more different voices, etc. So inclusion, no? So that's super important.
So I want to get to our last panelist and ask a question. I do want to emphasize that some of the things that work in one context, like the Nordic context, Colombia held hearings to figure out criteria for the inclusion, the updating of the new social insurance program. And it didn't have the inclusive egalitarian effects that it may have in Norway and Sweden. So it just depends a lot on the democratic context as well. So I want to ask one last question about philosophical perspectives on human rights that include Normans but also go beyond them, because I think there is now a divorce as between those who take international law and the proliferation of statements and general comments and special rapporteurs' reports as some kind of positivistic starting point, and philosophers who are increasingly critical of that. So I'm wondering if you could speak to that in particular in regard to health issues and what that divorce means for health systems.
Yes,
you know.
absolutely. Thank you so much. Is this all right? Yeah, thanks very much for that question, and thanks very much for your talk and for this discussion. I found it really fascinating. I'm going to come in as the provocateur here, as a philosopher coming in, raising provocative questions about this discussion and about the broader discussion, precisely as you pointed out. There are those, and actually as Norman brought up in his talk, you distinguish at one point between the issue of the moral right to health, on the one hand, which you ground in a liberal framework in equality, fair equality of opportunity, on the one hand, and which may or may not be a universal moral right. That might be a right that is grounded in liberal values that are culture specific. I don't think that myself, but it might be argued that that is the case. And on the other hand, the positive human right to health, or the human right to healthcare. I think that's a very important distinction, and some of my own research focuses on the connection between what we call human rights in a moral sense, on the one hand, universal moral rights held by all humans, and positive human rights that are creatures of law, on the other hand. So the provocative question that I want to raise, though, that comes to this, I take it that we are, by and large, focused on the positive element, the positive law, which does exist. It's out there. My question is what human rights talk and what the normative framework of human rights, the legal normative framework, and possibly operating in the background, the moral normative framework of human rights brings to these discussions. You've all raised really interesting points about first of all, the need for priority setting in healthcare, and potential differences and similarities in the way that healthcare priorities are set in different countries, in poor countries and rich countries. My question is, I haven't heard very much talk about human rights. It seems to be operating in the background as a sort of value, this idea that everybody should have access to something regarding their health or health care, given that we all have a very, very strong fundamental interest in being healthy and having access to health care. But it's not clear to me how human rights, how this idea of a right to health is meant to actually help frame our discussion about how to set priorities. So one way in which that might work is to say, look, so I take it that this is the way that the human right to subsistence that we see in Article 25 of the Universal Declaration, for example, which includes healthcare, by the way, but it includes things like the right to food and the right to clean water and things like that. That could function in a way as to say, look, there are lots of ways in which we can structure our societies with regards to the distribution of resources in general, but there are unacceptable ways of structuring our societies, and those include ways that involve denying people access to certain basic necessities like food and clean water and shelter and things like that. So we could put healthcare in there, but of course there is this problem of how much healthcare do people have to have access to in order to have that minimum. So I guess my question, just to sort of summarize, is exactly this. How does thinking about the human right to health help in priority setting at that level? And why not instead just focus on, you mentioned the Millennium Development Goals. Goals and rights are not the same thing. Why not just treat health as a social goal, given its importance for people? What do we get out of talking about rights as opposed to goals? So it's a question rather than a comment.
So that's great, and that's a great way to, I think, just open it up. We don't have that much longer, but instead of us trying to answer those questions, why don't we take questions from the group? Yes, you're, okay. Joey?
Close to your mouth.
Hi, thank you everyone for your great comments and your presentations. I have a question for Norman Daniels and Roberto about deliberation. In priority setting, you talked a lot about expert deliberation, judicial deliberation, political deliberation, and I was wondering what you believe the role of citizen deliberation is. I'll be speaking a bit on the abortion lawfare panel about the Irish Citizens Assembly process. So I'm curious what you think the role citizens can play in this deliberation, and whether you think that kind of citizen deliberation process is a good process for determining priorities. Thank you.
Well, we will discuss a little bit this afternoon about abortion and deliberation, but I can just point out that there was a recent process in my country, in Argentina, about abortion, and there was a process of public deliberation which included a lot of citizen participation, and I can only say that that was extraordinary, that it was super important. And so to put it a little bit more abstract, I mean, so one could have said in advance, well, issues of rights, of course, I mean, are so important, are so extraordinarily important that should be taken care by experts or judges or separated from society, and lots of doctrinaries also would say, I mean, even stronger, I mean, given the importance of this discussion, given the importance of rights, this you cannot mess with democracy. So this should be, I mean, decided in isolation or separated from the craziness of, so the opportunism and the rationality of democracy. And I think that the process we just have, for me, I mean, was an extraordinary demonstration of the contrary, so that there was an open process of discussion that was fabulous for all of us, no, participating. We learned a lot. Lots of people changed their views. We understood views of people we didn't like in advance, so we could dissolve prejudices. So I mean, so in the concrete, I mean, was fabulous. Even though I mean the result was not good for many of us, but in the abstract also I think was an interesting lesson. I mean, the things we care the most are things we should discuss the most. I mean, all of us. So it shouldn't be, I mean, expropriated from public discussions.
So I'm going to cut off that. I'm going to let Norman respond, but I think we'll have an opportunity on the abortion panel to discuss different kinds of deliberation that are afforded by referenda and other sorts of processes. Maybe Norman has a comment specifically? No? Okay. There are citizen councils built into certain health systems and deliberative processes that include social values, from Thailand to the UK to Chile, in different kinds of ways. So, you know, Siri.
So thanks a lot. Thanks a lot. It was very stimulating. I just and I think that sort of what's coming out of the discussion about the need to sort of get the better procedures, and even better procedures for resolving this tension that can't sort of be resolved purely through sort of theorizing, at least not at this stage. But then I want to go back to the question about, okay, so what about the children then? If it's about fair process, how do we include children? If children's rights are to be sort of taken account, then that is a particular problem, because there are challenges to including children. And we're going to discuss that, of course, throughout the week, but not everyone will be here for all the sessions. So, and you've been thinking about this, the process of health. So children, there are particular health concerns, as Norman was saying at the end. There are particular issues. We have, as Ulrich have said, that there are arguments that children should have a particular weight, but how do children's right to participate in the decisions that concern them, or to have their concerns represented? How do we do it in practice? Can you help us?
No, I think that's a challenge. So at least we need to develop systems where we represent the interests of the children and include them. And of course, we should talk about adolescents as well. So gradually including, which we do in a lot of legislation and in practice with respect to abortion, with prevention, including them in treatment, changing sex, male circumcision, should they be asked or not. We need to figure it out, and a lot of countries have developed different guidelines and ways to deal with that. But of course, more work needs to be done. And will be done through this week.
Well, I would just add that there are some subjects that are very unpopular, and the advocates are likely to have different conflicting interests. For example, children with psychiatric disabilities, for example. So I think that it's just a very, very complex area of how to represent children of different ages and across a range of health issues. Do you have?
Yes. So I think one of points of experience that I've had is that people in power refuse to concede their positions of power to inclusiveness in deliberation. And I think so. I would agree with you that the public deliberation in Argentina is very important because it's an example of inclusiveness. And I would argue that a lot of the less developed countries like South Korea, then Norway and Sweden have also thought of the importance of inclusiveness. And they have endorsed, so Juano has a paper in 2015, I believe, arguing what there is some of the results of the Korean acceptance of inclusiveness in deliberation. So I think this is an important development, but we don't know what to do with it because children are a real exception to participation in deliberation, especially the children you're most concerned about in some areas of interventions early in childhood. When the best interests of the family might be prominent on some people's minds, although that's changing, and it may be itself a feature of access of children to health care that is changing. So I don't have a good solution to your problem, except to argue that in favor of inclusiveness, but that comes from my concern for democratic process.
Can we just take one last question and then close? No? Okay, I'm getting no. We can't take one last question. Okay, thank you very much to all of the panelists, and thank you especially to Norm.